morning, everyone. Welcome back here at ESCMID Global TV. I am your host, Judith Cohen, and I'm very pleased to tell you that we have a very full day packed with lots of really interesting interviews for you ahead of us. And of course, also at noon, our Lucky Wheel of Fortune, your opportunity to win some really great ESCMID prizes. So stay with us all day. We'll be broadcasting to you every hour on the hour. And starting now, I would love to introduce my next guest, who's live here with me in the studio here in Hall 8.1 in Barcelona, Spain. And that is no one less than Professor Peter Openshaw, who's a respiratory physician and mucosal immunologist and a professor of experimental medicine at the Imperial College in London. And I am very excited to have a little chat with him on one of his favorite viruses, I believe, RSV,
yes.
On which you yesterday also had a Meet the Expert meeting called RSV Control Within Reach.
Within reach.
It's a very optimistic title.
I think it is within reach, and it's been a very, very long time. So I've been working on RSV for many decades. And at last, we do seem to have the potential to do something about it, both in children, but also in older adults and in vulnerable older people.
Yeah. So how was the situation decades ago when you started working with RSV?
Pretty hopeless.
Yeah.
I mean, when I first went into the field, it wasn't long since some disastrous vaccine trials in the 1960s. Which resulted not only in failure to protect, but also in enhanced disease. So children who were given this formalin inactivated vaccine went from being 5% hospitalized to being 80% hospitalized, and there were a couple of deaths. It was a terrible time. And I think many of us were despairing that there would ever be vaccines. And now the pipeline is full. It's been a very long haul, but we do finally have vaccines now on the market for adults. We have a very good protective pipeline of antibodies to protect children soon after birth. And I think there will be other vaccines too coming through. So it's very exciting now to see at last that we do have the potential to control this really quite terrible disease.
Yeah. So has the virus changed over the decades? So in how it presents clinically, or has it mutated much, or?
That's an interesting question. I mean, the virus has probably been in the human population in relatively stable form, probably for at least 100 or 1,000 years. We don't know. People are extrapolating according to the molecular clock of the virus that it may have jumped from cattle or some other species into humans and has become a well-equilibrated virus. So it does change a bit, but not radically. It does undergo some immune escape, but it's not like influenza. It doesn't have this compulsion to really mutate away from pressure of the immune system.
Okay. So many vaccines in the pipeline. We'll dive in deeper a little later. First, I would like to ask you, can you comment something on the diagnostic side? Because I can imagine that has taken a flight also over the past decades, or at least while you were working with RSV.
Yes.
So how was it when you started? Were there any diagnostics, and where are we now?
So when I started, people were still cultivating the virus in cells in the lab. You'd have to take a swab, take it to the lab, grow the virus and see the syncytia or see the cytopathic effect. That changed, of course, with the advent of PCR and of antigen detection, but it was never very reliable or useful, and it didn't really guide treatment. And indeed, many healthcare planners said, don't bother testing, because there's nothing you can do about it. There's really no point in having a diagnostic. And we all thought that the rapid antigen tests would be impossible for people to do themselves, and anyway, there's no point.
Challenging.
Challenging, yes.
Yeah.
I mean, all that, of course, changes if you do have a specific therapeutic.
Yeah.
And people have been working on antiviral drugs for RSV for many years, but there's nothing yet which is proven on the market. These work in human challenge studies. For example, if you take volunteers and you block the virus with the antiviral, you can show that it reduces virus excretion, and you
Yeah.
can also show that the symptoms are much less.
Okay.
But none of these have actually moved into clinical practice because in clinical trials, antivirals have relatively little effect.
So they don't work in patients who truly have the disease or
That's
disease
correct.
caused by the virus?
So far,
Yeah.
except for one or two studies which look interesting, but it hasn't translated yet into an actual therapeutic. So I think we're still in the situation that we have an exciting time now in terms of prevention,
Yeah.
but in terms of treatment, it's really supportive, directed at the symptoms
Yeah.
and directed at any problems that may arise.
So what could be the reason that it doesn't work in patients, but it does work in healthy volunteers? Because it can reduce viral load and
Yes.
symptoms.
Yes, it would seem obvious that that is the thing to do. You've got a virus you want to inhibit with an antiviral.
Yeah.
But actually the clinical experience is disappointing, perhaps because we don't really encounter the infection in the very earliest stages. You know, these viruses tend to have two phases, an initial virus phase when the virus replicates,
Yeah.
and then it moves on to an inflammatory phase when most of the symptoms occur in this as the virus levels start to decline.
So with
we-
the healthy volunteers, you're intervening just at the
Early.
right time, probably.
Whereas in people who present in hospital, they've often had the disease for 5, 6, or 7 days.
Yeah.
It's a bit late, really, for an antiviral to be
Yeah.
very effective at that stage.
And do you believe that there will be like such rapid diagnostics, like point of care tests being produced or
I think
developed for?
that's right. I mean, you can imagine that if we did have good antivirals that work,
Yeah.
and we had a point of care test or even the test in the pharmacy where you could walk in and you could take a multiplex test in the pharmacy and it would tell you, have I got COVID,
Yeah.
which we now know these strips
Yeah.
work for, have I got flu, have I got RSV, have I got human metapneumovirus, and then the pharmacy might provide you with the specific antiviral, and you've only been symptomatic for a day, so then it might work.
Yeah.
I think that's for the future.
Yeah. Well, we'll need to see if that's going to
We'll
fly.
have to see,
Yeah.
yes. Yeah.
Yeah. I myself come from the Netherlands. We're a very down-to-earth
Yes.
culture. So they probably say, well, just one day symptoms. Let's wait for a week or two.
Absolutely.
Yeah.
Yes.
But then you're too late. So there's a really small window of opportunity as the outlook is now.
Yes.
Yeah. So did you discuss during your Meet the Expert session, you discussed with some of the participants there more on the recent advances, on pipeline candidates, or do you care to comment
Yes.
a little bit on
So-
what happened in the session?
So as an adult chest physician,
Yeah.
I've always felt a slight anomaly in the RSV field, at least initially, because it was thought only really to be an important virus of children, particularly of early life. The first 6 months is the most dangerous period for children.
Yeah.
The infant chest is still adapting to extrauterine life. You know, before you're born, you know, your lungs don't breathe, obviously, and as you are born, then your lungs have to adapt to breathing air, and that takes months. So that critical period is when it's bad to get RSV.
Yeah.
So, you know, as an adult chest physician, it was slightly odd that I was working on this pediatric virus. But I think about 15, 20 years ago, we realized that actually it also causes insidious disease in older adults, which is often diagnosed very late. Perhaps the story might be that a child comes back for Christmas, meets grandparents. Grandparents are a bit frail, perhaps they've been smokers, perhaps they've chronic bronchitis. They catch a cold from the children that are visiting, and by the middle of January, it's gone to their chest.
Yeah.
And by, you know, maybe the third week in January, they're admitted to the hospital. Diagnostic tests are done. No virus is sometimes evident by that stage, but that's the most dangerous stage of that disease, which has a high in-hospital mortality, but also a high 12-month mortality once those people have been discharged from hospital. And that's
Why
actually...
is that?
People don't know really. It could be that your lungs already harbor some inflammation, the so-called inflammaging that happens in many organs, and the virus adds to that inflammation. So it's virus inflammation on top of inflammaging causes a deterioration in lung function, and also loss of other functions, you know, daily living, people decline quite fast after they've had an RSV infection.
Yeah.
It could also be, obviously, that it's not the virus that's causing it, but the virus which is marking people who are already sick
Yeah.
and maybe are going to decline over that time in any case. But,
Yeah.
but it's that group that are now being effectively protected by the vaccines which have already been introduced in the last winter season in North America.
Yeah.
And about 25% of people who were eligible for those vaccines actually took them up.
Okay.
And we're looking to see what impact that has on elder health.
Yeah. So which group did they do? 50 years and older, or 65 years older? Or?
It's an interesting question. Yes, so the trials were generally 60 and over or 65 and over, with very few people in the truly old, frail 75 plus group.
Yeah.
The recommendation in the US was 60 and over. In the UK, we went for 75 and over, I think as a cautious first step into the recommendation for vaccine use.
Yeah.
And I think we're all waiting to see real-world data as to what the true impact of these very, very effective vaccines are going to be, because it looks like they prevent at least 80% of lower respiratory tract disease due to RSV.
Yeah. So do you offer also the vaccine, or do you think the vaccine should be offered to people who already have an inflammatory lung disease and COPD or asthma,
Yes.
that they should be offered the vaccine at a younger age already?
So
are they more at risk?
That's right. So data has been presented to those who license the vaccines with regard to people under the age of 60 with pre-existing lung disease. And to my mind, it's very compelling that they too would benefit from being vaccinated. We know that RSV can cause exacerbations of asthma.
Yeah.
I mean, more frequently it's rhinoviruses, but we just don't have any vaccines really in the offing for rhinovirus.
No.
But RSV is one that we can prevent, and which is particularly associated with wheezing.
Yeah. So would you say that maybe the best advance in this field of expertise is the making of the vaccines and the offering it now? Is that is probably
that to
because
me,
of the therapeutic agents being lacking?
Yes, prevention is better than cure, and that
Yeah.
absolutely applies to these viruses.
Yeah.
You could say that actually one of the most exciting things is this long-acting antibody. At the moment, we've got nirsevimab. I don't know if I'm allowed to name drugs, but nirsevimab is it's a long-acting antibody which has got a very long half-life in the circulation. It replaces palivizumab, which has been licensed some years ago, which had to be given once a month, so 5 injections during the winter season for vulnerable young babies.
Yeah.
So one shot of nirsevimab, this new long-acting antibody, will last through the whole of the winter season, and that's been introduced as a blanket recommendation in some parts of Spain, in France, in Luxembourg. We're still equivocating in the UK because we don't know what price we can get. That's really amazingly effective. We already have real-world data on the nirsevimab introduction in Galicia, and it's so impressive to see that the wards are empty.
Wow.
Babies that always has been a winter surge in admissions of babies due to bronchiolitis. That's abolished effectively by this one-shot passive vaccine. So it's not like a normal vaccine, but it's similar in that it's a single injection.
Yeah.
You can give it.
So you give it to vulnerable babies?
Just give it to
who
all
are
babies.
Give it to all.
So that's what they've decided.
I would
to
say
do.
every baby's vulnerable.
With palivizumab, it was so expensive that we limited the course of injections to those who are most vulnerable.
So the premature.
Yeah, premature, low birth weight.
Yeah.
And cardiopulmonary disease, existing risk factors. But it was complex, really, to assess the risk. And babies were still being admitted because they weren't in the risk groups, but they still got the disease. So there is an argument for just blanket prevention with nirsevimab, which is what they've gone for in some countries, some European countries. That makes a lot of sense, but it's expensive.
Yeah.
I think if the price could come down so that it was, really cheap, it would be great to just prophylax all babies.
Yeah. So if I can summarize you correctly, I hope, RSV control is within reach.
Yes,
Yeah, through prevention. Yeah.
yes,
Yeah.
rather than treatment. I
Rather
think
than
there
treatment.
is a gap.
Yeah.
In older children, what I would love to see is a live vaccine that can be delivered as a
Yeah.
nasal spray, like
yeah.
live attenuated influenza vaccine,
Yeah.
and that would fill the gap between the babies and the older adults, and it would also probably limit spread in populations and
Yeah.
in homes where you have multi-generational
Yeah.
families. So that would be the next bit of the puzzle.
Is it already in the pipeline?
Tests are being done. I mean, it's been a very, very long
Yeah.
time in the testing.
Yeah.
I'm optimistic. I'm a mucosal enthusiast as well as being an RSV enthusiast. And that's the bit which I would like to see next.
Well, this world needs more optimists and
Yes.
enthusiasts. Thank you so much, Peter, for taking the time and effort in your busy schedule this ESCMID Global to come here and give us a little bit more information on RSV. Thank you so much.
Great pleasure.
Thank you all for watching. We will be back at 10 o'clock sharp, and we will be speaking with another keynote speaker, with Jeannie Marazzo, and we will be talking about her keynote scientific interview on the syndemic of HIV and STIs. So tune in at 10, and I will see you then.